checked it on yesterday once, so, that
Yeah.
increases the comfort level. We're sure what to expect.
Yeah. Yeah. Thank you for help.
Oh, most welcome.
So are you allowed to go out and shop?
Right now, it depends on which city you're in, but Pune and Mumbai, we used to have 2 hours or 3 hours of time, say between 10 and 12. But because a large number of cases now, in the next 2 or 3 days, I think all the shops are going to be closed for about 4 days till 26th.
All the shops.
So nothing is going to be available, and it's going to be a tough time. So people have to depend on whatever they stored or whatever they have. So it's like a complete lockdown. They want to, sort of, there are containment zones that they want to look at, and, case finding and quarantining and all that thing. So it's getting tougher now.
Wow.
Okay.
That's much stricter than here.
Oh, yes. Yeah. You won't find anybody on the streets as much as most of the day, but, those 2 hours when it was allowed, people would go out and get groceries or something, fruits or whatever. So shall we start, Sita?
Yes. 160 people, I think good number. People
I think
are joining.
it's a good people will join in, and let's see how many people join in. So I think let's begin.
Yeah, you introduce. Yeah.
Okay. Good evening, everyone, and welcome to the night webinar of FINE. And today we have Professor Pavel Klein from Mid-Atlantic Epilepsy and Sleep Center at Bethesda in Maryland, USA, who has very kindly offered his knowledge, expertise, and time to talk to us today on a very important topic, which is very close to our heart because it impacts our patient care. Recent advances in the treatment of epilepsy. And he will be also telling us about where the new anti-epileptic drugs are positioned in terms of, when to start them, when to add on, is it to be a first add-on or later on? What are the issues related to specific patient populations in different types of epilepsy? And Dr. Pavel Klein has, graduated from Harvard and then gone on to be in major pivotal trials of anti-epileptic drugs. And he is a very well sought after expert on anti-epileptic drugs. He also has interest in sleep. As you can see that he runs the Epilepsy and Sleep Center. He is the founder of that. And he also has research on post-traumatic brain injury and seizures. So over to Professor Pavel Klein, and he has been to India several times, and we've had the opportunity to listen to him. Many of you have heard him, so we look forward to his talk again. Thank you, Professor Pavel. Over to you.
Thank you so much, and thank you for giving me the opportunity to talk to you all. I hope you're all comfortable in your homes and surviving the lockdown as we are here. So I will talk about some of the recent advances in the treatment of epilepsy, and the talk will be somewhat eclectic, and I would like to leave the specific applications that you just mentioned, to which drugs to use when, for which patients, to the question and answer part of the talk. As you all know, there's been a large number of drugs developed over the last 150 years, and the number of development has escalated over the last 15 years. This is the list of them that I'm sure you've all seen. And you've also seen, I'm sure, this version of the slide, which shows the proportion of patients who become seizure-free with treatment with medications. The first such study was published in '85 in New England Journal of Medicine, when only carbamazepine, phenytoin, phenobarbital, and primidone were available. And you can see that 39% of patients became seizure-free with any one of those medications, seizure freedom being defined as no seizures over 12 months. Fast forward to the data that you all know, Kwan and Brody published in 2000, when some of the newer anti-seizure medications became available, including lamotrigine, trileptal, etc. and the proportion of patients who become seizure-free did not change that much. With the first medication, 47% of patients; with the second medication, 13%, third and further 4%, and about 36% of patients remained uncontrolled with medications. And then fast forward to the most recent iteration of the same cohort of patients added to it over the years, published in 2018. And basically the situation is unchanged. You've still got about 35% of patients who do not respond to treatment in spite of all these 30 odd medications that we have now available in our repertoire. So have we done anything with the discovery of the medications? And I think the answer clearly is yes, we have. Many of the new medications have much better tolerability and safety profile. Many of them have very simple pharmacokinetic profiles, which makes them very easy to use. Less drug-drug interaction, which again makes it very easier to use, particularly in patients who have to have other medications, be it other anti-seizure medications or other medications, such as, for instance, in the elderly. And I think very importantly, in terms of epilepsy, the lack of seizure freedom shown in those pie charts that I just showed you belies the fact that for many patients, seizures are less frequent and less severe, meaning fewer secondary generalized tonic-clonic seizures and focal seizures, and fewer seizures. And that's really reflected in the fact that with each new anti-seizure medication study, it's more difficult to recruit patients into the studies because there are fewer of the most severe patients to be recruited from. So I think the new anti-seizure medications have clearly improved care of epilepsy and have improved quality of life. However, a number of unmet needs remain, and they're major unmet needs. So the first one is refractory epilepsy, those 35% of patients who don't respond to medication or other treatment. And then really importantly, the fact that while we have medications and we treat successfully about 2/3 of patients with epilepsy, we really are doing it without knowing what we're doing. Our treatment is based on empirical treatment. We try one medication, we don't know whether it's going to work. If it doesn't work, we try another medication. We don't know whether it's going to work. We don't know whether there'll be side effects. And if that doesn't work, we try another medication. It's completely trial and error. We don't have at the moment, for the most patients with epilepsy, precision medicine, meaning targeting the patient's disease and the patient's triggers of seizures with specific therapy. Other unmet needs, refractory status epilepticus, about 1/3 of status epilepticus goes on to be refractory and super refractory with high mortality, SUDEP, and very importantly, prevention of acquired and genetic epilepsies. So I'm going to focus primarily on the refractory epilepsy tonight. The new medications that we've seen in that Jacob's ladder slide include a number of different anti-seizure mechanisms of action, and they fall basically into 4 categories. So most of these anti-seizure medications that are on the market now address excitability or synchronization, mainly excitability of neural networks. And they do it in one of 4 main ways, either by modulating voltage-gated channels, either sodium channels, such as with medications such as phenytoin, carbamazepine, lamotrigine, or lacosamide, calcium voltage-gated channels with ethosuximide, a voltage-gated potassium channel with retigabine, which has been withdrawn from the market, but which has a second generation follower now in phase 2B trial. The second mechanism of action is enhancement of GABA-mediated inhibitory neurotransmission, and that's benzodiazepines, tiagabine, vigabatrin. And then third, recently added attenuation of glutamate-mediated excitation, and that's perampanel. And then finally, also relatively recently added modulation of neurotransmitter release via presynaptic action, and the medications that fall into that category include levetiracetam and brivaracetam, and gabapentin and pregabalin. With that said, all of these medications affect brain excitability. They interfere with the generation of seizures and propagation of seizures. but they don't address the specific defects that are pathogenic in epilepsies. And that, again, is the lack of precision medicine. Now, changes are afoot, and they stem particularly from the group of rare diseases, particularly mainly affecting children, that have genetic or other identifiable causes that have led in the last 10 years or so to development of precision targeted therapies that may lead to precision medicine, including novel therapies such as antinucleotide oligosense therapy, genetic therapy, and such like. But those, even when they do become developed, hopefully in the next 5 or 10 years, will still leave the vast majority of patients with epilepsy unspoken for. So that sort of brings me to the empirical versus precision medicine. It's a strange thing that with all these medications that we have, we really do not know how to treat any one patient. We have no way of predicting response either with efficacy or with side effects for any one medication, for any one patient, except for a small handful of diseases that I'll mention in a minute. So the precision medicine that we've been talking about for the last 5 years or so really is a, quote, lofty goal, unquote, and not reality at the moment. The lack of understanding goes both for the way the medications act, but also for pharmacogenomics. So in psychiatry, for instance, you've got a number of medications whose response can be gauged by pharmacogenomics, metabolism of the medication, the presence of fast or slow metabolizers, etc. In epilepsy, we really don't have that. Our pharmacogenomic armamentarium is restricted to prediction of allergic reaction with medications such as carbamazepine or phenytoin, and slow, fast metabolizers for some of the hepatically metabolized medications such as carbamazepine and Depakote. So we have a long, long way to go. There are certain conditions where precision medicine is a little closer, a very small number of them. Dravet, of course, which is due to SCN1A mutation in about 80% of cases. And there, the treatment that's, quote, precise, not so precise, is avoidance of sodium channel blockers. More precise in GLUT1 deficiencies due to cerebral glucose deficiency and glucose-1 transporter deficiency, a genetic condition. The treatment of choice is relatively precise, and it's ketogenic diet, whereby you're substituting an alternative source of energy for glucose. In tuberous sclerosis, everolimus is a specific form of therapy. And in a very rare condition, neurosteroid lipofuscinosis type 2, there is now replacement of the missing protein, liponase alpha, and that is a precise treatment, again, affecting a very, very small number of patients. And then finally, pyridoxine-dependent epilepsy, neonatal seizures treated with pyridoxine vitamin B6. So that's a very small number of diseases affecting a handful of patients where we do have precise treatment. For the most part, we do not. So I'm now going to move on to discussing a few medications that have been developed in the last few years. Since 2013, they've included Perampanel, Brivaracetam, everolimus, cannabinol, and Cenobamate. I'm going to talk about Perampanel, Brivaracetam, Cenobamate, and one that's not on there, fenfluramine, and it's not on there because it has not been yet approved by the FDA, although it's under consideration for approval. So I've chosen to talk about Perampanel, even though it's a relatively old medication, because of its key importance in addressing a pathophysiological mechanism of action, namely blockage of glutamatergic transmission. So Perampanel is a non-competitive blocker of AMPA receptors. AMPA receptors are key to generation of seizures, as shown on this slide. So you can see in hippocampal slices, generation of picrotoxin generates excitatory potentials, and those are associated with seizures. You've got the depolarizing potential. If you block one of the metabolic glutamate receptors, the NMDA receptor, you get the blockage of the late response, but not of the early response. If you block AMPA receptors, you've got blockage of the whole response. So that is clearly evidence for to show the importance of AMPA receptors in generation of seizures. As it happens in human tissues of patients with refractory epilepsy, there is increase in expression of AMPA receptors shown in the red here in slices from hippocampus of patients compared to control where you do not have such a dense expression. The perampanel acts by binding to the glutamate receptor extra outside of the membrane, and it blocks the effect of glutamate in opening the ion pore for glutamate, keeping it closed in a non-competitive manner. So you'd think that this would be a dramatic breakthrough in the treatment or potential for treatment of epilepsy. So what are the actual results? So there were 3 pivotal studies. You all know them, I'm sure, the results of which are shown here for efficacy. So in terms of median % of seizure frequency reduction, it ranges from 25 to 35% compared to 10 to 20% for placebo in doses ranging from 4 milligrams per day to 12 milligrams per day. So yes, improvement, dramatic improvement, no. Perampanel is metabolized by in the liver by CYP3A4 and 5 isoenzymes. And so it is in that isoenzymes induced by medications such as carbamazepine, oxcarbazepine, phenytoin, and topiramate, with the result of dropping of perampanel level anywhere from 40 to 65%. And so that is reflected in the efficacy. So if you analyze the studies by presence of enzyme-inducing medications as concomitant medications, you get a lesser response than if you look at patients who did not have concomitant enzyme-inducing medications. You can see that at the 8 and 12 milligrams, the response is more robust, 45 to 55% of seizure frequency reduction. So that's an important consideration. Another interesting thing about the pharmacokinetics of perampanel is the long half-life, 105 hours without the inducer's presence. Perampanel is also effective in primary generalized epilepsy. So in a pivotal study of primary generalized epilepsy, there was a 76% seizure frequency reduction compared to 38% in placebo. And when you looked at categorical response, 48% of patients treated with perampanel 8 milligrams per day had 75% to 100% seizure frequency reduction compared to 24% of patients treated with placebo. With that said, what is the rate of seizure freedom with perampanel? Roughly 2%. So not that high. The side effects of perampanel are very well known. They include primarily dizziness, somnolence, and then notoriously irritability, and even more notoriously anger. So the somnolence and dizziness occur, are dose proportionate, as seen here. With fatigue being similarly dose proportionate. Irritability occurs in about 8 to 12% of patients in the higher doses, 8 to 12 milligrams. About 4% of patients not different from placebo at 4 milligrams, and about 3% of patients have the bad form of irritability, namely anger. Leading to in 6 out of 4,500 subjects evaluated in the perampanel development to the homicidal ideation for which perampanel has the black box warning. The main reasons for discontinuation of, due to adverse events is dizziness and somnolence. So what is the potential of perampanel? You know, given the fact that it is a medication that blocks a key process of ictogenesis, the results have been less than one would have hoped for. Nevertheless, perampanel does have clear advantages. It can be used for both focal and primary generalized epilepsy. So that's a very good thing. It's got a long half-life. So in patients who may be non-compliant or who may lose access to medications, for instance, in situations like we're in now, in the lockdown, that may be an advantage. And it's useful to have an agent for refractory primary generalized epilepsy, for which there are not that many other medications: Depakote, levetiracetam, topiramate, zonisamide, lamotrigine. The disadvantages of perampanel: it's slow titration, so you start at 2 milligrams and you titrate in 2-week steps. Usually not shorter than that, sometimes longer than that, 2 milligrams per 2 weeks. But you can have efficacy in some patients at 4 to 6 milligram dose, so a relatively low dose. And the hostility and anger potential is relatively low at doses less than 6 milligrams. So one thing that I think has not been explored, which I would be very interested in having an answer to, is whether the mechanism of action of perampanel may lend itself to combination treatment with other medications and improvement in treatment of refractory patients with both rational polypharmacy, combining the drugs with different mechanisms of action, including this key one of blocking glutamatergic AMPA receptor activity. Along the same line, a question whether perampanel will be useful in status epilepticus. There's some preliminary data in animals and some anecdotal data in humans, but no studies have been done. And for the same reason, because of the importance of glutamatergic excitotoxicity in epileptogenesis after acquired disease such as TBI, could perampanel have a role in epileptogenesis? And that too is yet to be explored. So the next medication I'm going to talk about is brivaracetam, and I think most of you know the story here. The main differences between brivaracetam and levetiracetam are the higher binding affinity of brivaracetam to the SV2A ligand. As you know, brivaracetam was rationally designed for that purpose, amongst a large number of analogs of levetiracetam, to discover molecules with higher binding affinity for SV2A than levetiracetam. That's what led to brivaracetam's initial evaluation and subsequent clinical evaluation and approval. It's not the only difference. So brivaracetam does have 15 to 30-fold higher affinity for SV2A compared to levetiracetam. It also is more selective. So levetiracetam also acts on AMPA receptor and also on the voltage-gated presynaptic calcium channels. Brivaracetam does not, and there's been some discussion about whether that might be related to the lesser propensity of brivaracetam to psychiatric side effects that may be seen. It also is more lipid soluble than levetiracetam, and it has a faster penetration into the brain, as shown here in animals. So in animals and in humans also, the plasma peak level of brivaracetam coincides with brain peak level virtually after IV injection. With levetiracetam, there's a delay. And then clinically, brivaracetam is liver metabolized. So in patients with renal impairment, that does not impact brivaracetam, and it is initiated without titration, unlike levetiracetam. So those are some of the differences. The SV2A biology is very interesting and has contributed a lot to our understanding of epilepsy. So both brivaracetam and levetiracetam act on SV2A. SV2A is the transsynaptic protein on the synaptic vesicles, and it modulates synaptic release of neurotransmitters at all the stages of the release, including the uploading of the neurotransmitter, migration of the vesicle to the synaptic membrane, the fusing with the membrane, and then release of the neurotransmitter load into the synapse, and then recycling back. Both levetiracetam and brivaracetam slow the cycling of the synaptic vesicles going through the cycle. So you've got a pool of reserve pool of synaptic vesicles loaded with neurotransmitters. They get activated with fast action potential train. They go to the membrane with that fast action potential train. release the neurotransmitter, and then migrate back into the cytosol. Levetiracetam slows down that cycling, and brivaracetam slows it down further. So that's the main, that's the mechanism of action. However, we still don't know how that impacts seizures because the mechanism of action is not really selective. So it affects both glutamatergic as well as GABAergic containing vesicles, as well as vesicles containing other neurotransmitters. So we don't really know how that modulation of the SV2A action translates into seizure reduction. As I mentioned before, levetiracetam and brivaracetam can be given IV. They both penetrate the brain. And in studies in humans where a radioactive ligand was injected into healthy volunteers and then was followed by injection with IV levetiracetam or brivaracetam to look at the rate of displacement of the radioactive ligand to tell us how quickly the drug binds to the target molecule in humans, brivaracetam had a half-life of binding to SV2A in a human brain of about 2 to 3 minutes, levetiracetam about 27-30 minutes. So brivaracetam gets to the SV2A molecule really, really fast. The pharmacokinetics of brivaracetam are very straightforward. It's 100% bioavailable. The Tmax is 1 to 2 hours. It's sparsely protein bound. It's metabolized in 3 steps by the liver to inactive metabolites, and then is renally eliminated. Half-life is about 9 hours, and time to steady state is about 2 days. So the efficacy of brivaracetam is well known from the 3 pivotal studies. The median percent seizure frequency reduction with the 100 and 200 milligrams is about 25%. With the 50 milligram per day dose, and those are the 3, this is the dose range that's been approved, it's about 17-19%. The responder rate is also dose dependent. So for placebo, the responder rate, meaning 50% seizure frequency or reduction or higher, was 20% for placebo, and then 35% for 50 milligrams per day, and about 38-39% for the 200 milligram per day dose. If you look at categorical seizure reduction, the 75% responder rate, which is one that we're really most interested in, has about 20% seizure frequency reduction, or 20% of patients have 75% seizure frequency reduction or higher. With the 100 and 200 milligram per day doses, it's about 13% with 50 milligram per day dose. The seizure freedom rates are shown here. So they're 2.5% for the 50 milligram per day dose, and 5% for the 100, and 4% for the 200 milligram per day doses. Now, very interestingly, brivaracetam is extremely effective in blocking secondary generalized tonic-clonic seizures. So for 100 milligram per day dose, the median seizure frequency reduction of secondary generalized tonic-clonic seizures is about 63%. For the 200 milligram per day dose, it's about 82%. So highly effective in that particular form of focal seizures. As you know, it's been evaluated in patients who failed levetiracetam. So in the largest study of brivaracetam, about 55% of patients had been on levetiracetam before, but were not taking it at the time of brivaracetam exposure. And those patients still had improvement in seizure frequency shown here. It was not as high as patients who'd never been exposed to levetiracetam, but it was still high enough, for about 28 to 31% for the 100 and 200 milligram per day dose seizure frequency reduction, compared to 17% for placebo. And in terms of differentiating whether there was response depending on whether patients failed levetiracetam because of lack of efficacy, which was about 2/3 of the patients, versus side effects, about 1/3 of patients, you had a response with levetiracetam for both reasons of discontinuation, with brivaracetam for both reasons of discontinuation of levetiracetam, although again, the response was higher if patients had failed levetiracetam because of side effects. So the side effect profile of brivaracetam is very benign, and it's really told best by the rate of discontinuation of patients from brivaracetam because of side effects, and this was 5% for patients treated with 50 milligrams, and 8 and 7% for patients treated with 100 and 200 milligram per day dose in the pivotal studies. this is a very favorable rate. The main side effects, again, are very benign: somnolence, dizziness, and fatigue. Those are the three main side effects. They are dose proportional for the somnolence, but not really for the other two. Irritability occurred in about 3% of patients treated with brivaracetam versus 1% of patients treated with placebo, and insomnia, 2.5% of patients treated with brivaracetam versus 1.5% of patients treated with placebo. Psychiatric side effects are relatively benign. Again, irritability, 3% versus 1%. Anxiety, 3% versus 2%, so not statistically significant between active and placebo-treated patients. I mentioned insomnia, depression, 2 versus 1%, brivaracetam versus placebo, so not different between placebo and active medication. And psychiatric side effects leading to discontinuation of the medication in the pivotal studies were 1.7% for patients treated with brivaracetam versus 1.3% of patients treated with placebo, so not statistically different. So good side effect profile. This is held up also in long-term evaluations. So in a long-term open label extension study with follow-up for up to 8 years, the psychiatric side effect profile shown here, and again, was relatively benign. So this has been utilized in terms of trying to see whether patients who'd done well on levetiracetam but had psychiatric side effects would shed those psychiatric side effects when switched to brivaracetam. The first such study was done as a controlled phase 3 study, and patients who'd been seizure-free on levetiracetam but had psychiatric side effects that were intolerable were switched overnight to brivaracetam. 62% of those patients became free of the psychiatric side effects. 90% of them had improvement. 2 out of 29% of patients had worsening of seizures. The rest of the patients continued to be seizure-free. This has been evaluated in a number of post-marketing studies, so real-world experience studies with a total of roughly 1,000 patients exposures. And you can see that here, these are studies that didn't look exclusively at patients who had been pre-treated with levetiracetam, but that looked at all patients that were refractory and were treated with levetiracetam. Most of these patients, in fact, had had prior levetiracetam exposures, shown here for the different studies, ranging from 40 to 100% of patients previously exposed to levetiracetam. And you can look at the improvement of psychiatric side effects, ranging from 50 to 75% of reduction or disappearance of the psychiatric side effect profile. So that's a clear indication for use of brivaracetam. If you've got patients who are on levetiracetam, they're doing well, they do have behavioral side effects, it's definitely worthwhile trying to switch them over to brivaracetam. Now, one thing I didn't mention in talking about the pivotal studies is the fact that all of these studies differed from the previous studies done for evaluation of new anti-seizure medications in one respect, and that was that there was no titration. All 3 of the pivotal studies were done with no titration because in the phase 2 studies, the tolerability profile was good. And so that has resulted in a situation where you've got a medication that can be used without titration. And we looked to see whether that makes a difference or whether that's has any relationship to the clinical impact of the medication. And what we did was we looked at what response by the time during the study. So response looking on the first day of the study compared to the baseline, second day of the study compared to the baseline, and so on and so forth throughout the whole 12 weeks of the study, to see when in the study the response occurred. And we find that we also made the condition of the analysis more rigorous in that we only accepted patients whose response was sustained. What does that mean? That means that from the day when you first saw the response, let's say day 15, the patient could not lose that response until the rest of the study. When we look at the overall responder rate that I've talked about until now, that is a pooled cohort of all the patients. It includes patients who had 50% seizure frequency reduction who dropped out because of side effects. It includes patients who had no seizures during the first 6 weeks of the study, and that had many seizures during the last 2 weeks of the study, but still had on average 50% seizure frequency reduction. Well, we eliminated those patients in this analysis because we wanted to see what was the response at a particular time of the study that was sustained and did not stop. We call that sustained response, and we looked at sustained seizure reduction of 50%, the standard responder rate, by treatment day. And when you look at this slide, which looks at 50% sustained seizure reduction, again comparing each day of the study to the baseline, you can see that on first day of treatment, you've got a difference between placebo, where you've got 7% of patients with sustained 50% seizure reduction. That's interesting. 15% of patients were treated with 50 milligrams per day, but 20% of, or 18, 19% of patients treated with 120 milligrams per day have sustained reduction of seizures by 50% from the first day on. And that turns out to be about half of all the patients who reach that 50% seizure frequency reduction. So when you think about it, about 20% of all patients treated with brivaracetam have 50% seizure frequency reduction from the first day. And that, I think, is very significant because it sort of gives you a comfort to say that when you treat the patient in the clinic today, you have a good chance of them responding. About half of all the patients who will respond do so on the first day when you start the treatment. Well, we then were interested to see whether this holds for higher rate of seizure response. And we looked at 75% responder rate, and we found the same thing. So that's shown on this slide, where you see that about 11%, 10-11% of patients treated with brivaracetam 100 to 200 milligrams per day had 75% seizure frequency reduction on the first day of treatment that was sustained for the rest of the study for the remaining 12 weeks of the trial. And that, again, was about half of all patients who reached that 75% responder rate. So again, even with this higher responder rate, you have a significant proportion of patients, about half of them, who respond on the very first day of treatment. Well, what about the worst kind of seizures, the secondary generalized seizure, tonic-clonic seizures? We looked at that also, and a remarkable thing that we saw was this. There was sustained seizure freedom from secondary generalized tonic-clonic seizures in about 32-36% of patients treated with 100 milligrams to 200 milligrams of brivaracetam from the very first day of treatment. So everybody who had sustained seizure freedom achieved at any time during the 12 weeks did so from the very first day of treatment. And that's quite remarkable. And I think, again, it's particularly important for these patients who have the most severe type of focal epilepsy. So to summarize, brivaracetam's got good efficacy, very benign adverse event profile. You don't need to titrate it, and you've got rapid onset of action. Virtually no drug-drug interaction. So to me, it's a medication that is great for initial treatment of focal epilepsy. It's also useful in patients who are renally impaired because it's not renally cleared. There is question about whether it could be useful for status epilepticus. Again, it's not indicated for that. There have been animal studies that suggest that it may be very effective in status epilepticus, and there have been anecdotal, there have been small case series, total about 75 patients by now, that suggests that a proportion of patients with adjunctive treatment of brivaracetam in refractory status may respond, but these are uncontrolled studies. The medication is not indicated for treatment of status. The same goes for epileptogenesis. Again, there's interest to see whether brivaracetam could be effective. The SV2A alteration is important in epileptogenesis after acquired injury, and so that's an interesting question. Now I'm going to move to the last major medication, and it's Cenobamate. So Cenobamate was approved in the US in November 2019. It's about to be released to the markets in May of this year. It's a medication that's a member of the Bamate family that was developed back in 1990s. The mechanism of action is uncertain, so we know what it does. It inhibits the non-inactivating persistent voltage-gated sodium channel current, and that leads to a decrease in repetitive neuronal firing. And it has a mild positive GABA-A allosteric modulating effect. It's effective in preclinical models across broad spectrum of animal models. The pharmacokinetics of it are interesting. It's virtually completely absorbed. It's got 60% protein binding. It's got a long half-life, 50 to 60 hours, so it takes 2 weeks to reach steady state, and it is metabolized by CYP450, 2E1, 2A6, 2B6, and UGT isoenzymes. It is primarily renally excreted. There have been 3 pivotal studies, and this is very interesting. So there were only 2 efficacy studies, both of them phase 2 studies. One was with treatment of maintenance treatment of 6 weeks, the other one maintenance treatment of 12 weeks. And at the end of those 2 efficacy studies, the FDA found the findings convincing enough not to ask for another for phase 3 efficacy study. So that's sort of breaking the mold. However, the FDA did ask for a safety study, and there was then a large phase 3 open label safety study, which was part of the pivotal studies. So the largest phase 2 efficacy study was a phase 2B study involving about 400 patients using Cenobamate at doses of 100, 200, and 400 milligram target doses. Compared to placebo, patients were started at variable doses. Initially, the starting dose was 50 milligrams per day. This was found to be intolerable, so the titration schedule was changed, and patients were increased in the doses every 2 weeks to reach the targeted dose. The maintenance treatment was 12 weeks, so total treatment period of 14 weeks. The demographics and the disease characteristics of the patients are shown here, and they're similar to all the other studies that have been done in the last decade or so. So what are the results? The results are really interesting. So the primary outcomes were either the percentage seizure frequency reduction during the whole treatment period of 14 weeks. And you see that here. So there was 24% seizure frequency reduction for placebo, 36% for patients treated with 100 milligrams, 55% of patients, 55% seizure frequency reduction for both 100 and 400 milligrams. Now, that's a very high percentage of seizure frequency reduction. It's interesting that it's the same for both doses. And the reason for that may be the titration period and the long half-life and 2 weeks to reach steady state. So by the time you've hit the maintenance period, you've lost 2 weeks, and that may account for the similarity for during the whole treatment period between the 100 and 200 milligram per day dose. Second primary outcome was the responder rate, 50% seizure frequency reduction or higher during the maintenance treatment period. And here you see that there's 40% of patients with 50% seizure frequency reduction at 100 milligrams, 56% at 200 milligrams, and 64% at 400 milligrams, compared to 25% of placebo. So this is quite unusual. More interestingly still, when you look at the very high response rate, the 75% responder rate, the 90% responder rate, and the seizure freedom, you see quite unusual findings. So at the 200 milligram per day dose, you've got 46% of patients with 75% responder rate and 21% of patients who were seizure-free. That is quite unlike anything else we've seen since the onset of testing of new medications. What are the side effects? By and large, the side effect profile is benign. It is clearly dose dependent. So discontinuation because of treatment emergent adverse events is dose proportional, 5% for placebo, 10% at 10 milligrams, 100 milligrams, 14% at 200 milligrams, and 20% at 400 milligrams. The main side effects are somnolence, again, dose proportional shown here, dizziness, same thing, and fatigue. You have the potential for ataxia, nausea, blurred vision, and then lesser nausea, vomiting, constipation. Those are the main side effects. There was one thing, well, I'll come back to one important side effect in a minute. The study was continued as open label extension. And this has been recently presented and is in development right now. 355 patients went into the open label extension. Of them, 64% continued. And you can see the rate of retention long-term at 2-year follow-up. You had 70% of patients continue with the medication. So that's a sort of telltale sign of the utility as well as tolerability of the medication. Importantly, the rate of seizure reduction that we saw during the placebo-controlled study is retained during the open label extension. So you're looking here at 50%, 75%, 90%, and 100% seizure frequency reduction during the last 6 months of the 30-month follow-up. And you can see that you have, again, 20% seizure freedom. And that is quite striking. So the seizure freedom is retained long-term. Among the 45% who are seizure-free, the median duration of seizure freedom was 33 months. So you've got a long-term seizure freedom. And if I had an hour to go over anecdotes, I could give you anecdotes of patients whose lives have been completely turned by becoming seizure-free on this medication. The seizure freedom of Cenobamate is shown graphically here compared to all the other medications that have been evaluated, or not all of them, but most of them that have been evaluated over the last 30 years. And you can see that the seizure freedom rate for Cenobamate is quite high compared to every other medication. Now, there was one potentially important issue that had to be considered. In the first 900 or so patients, 933 patients and healthy individuals exposed to the medication, there were 3 cases of DRESS, so drug reaction with eosinophilia and systemic symptoms, including 1 patient who died. This is a patient, a healthy volunteer who was started at this is 1 patient in the study that I just discussed, the C17 study, who started at 50 milligrams per day. DRESS is not uncommon with many anti-seizure medications. So with phenytoin and carbamazepine, it occurs in about 4 out of 10,000 cases. And it has been empirically discovered that if you start a medication with potential for cutaneous allergy or DRESS at a lower dose and titrate it more slowly, the risk of the allergic reaction, including DRESS, is mitigated. But a notable example of that is lamotrigine, where we use the slow titration just for that reason. So a large phase 3 study was designed to reduce dramatically the starting dose of Cenobamate from the 50 milligrams to 12.5 milligrams, and reduce the rate of titration from every week to every 2 weeks, going from 12.5 milligrams 2 weeks later to 25 milligrams, 2 weeks later to 50 milligrams, 2 weeks later to 100, 150, and 200. And the outcome of this study was adverse event profile, and specifically looking at rashes and looking at DRESS. And you can see that about 1.5% of patients did develop allergic rash, but with this slow titration amongst 1,347 patients treated, there were no cases of DRESS. The side effects were very similar to the pivotal study: somnolence, fatigue, gait disturbance, vertigo, diplopia. So with this slower titration, low dose starting dose, it would appear that the risk of DRESS is indeed mitigated, and the risk of rash is about 1.5%. So Cenobamate does have some significant drug-drug interactions. So it induces certain isoenzymes, CYP2B6, 2C8, and 3A4, and it inhibits 2C19 and 3A4 also. So it reduces levels of lamotrigine and carbamazepine, and it increases levels of phenytoin, phenobarbital, and clobazam. In addition, there's pharmacodynamic effect, which we think is present with other sodium channel blockers, including carbamazepine, including lacosamide, including lamotrigine. So you have the potential for dose-related side effects such as dizziness, somnolence, ataxia with the sodium channel blockers and with clobazam. With clobazam, it may be pharmacokinetic. The cenobamate inhibits 2C19, which is the isoenzyme that's responsible for metabolizing an active metabolite of clobazam and as methylclobazam into an inactive metabolite. And so it leads to elevated levels of N-methylclobazam and may then lead to toxicity that way. So when using cenobamate, I think what we'll likely end up doing is reducing dose of pharmacodynamically interacting medications such as lacosamide, carbamazepine, and lamotrigine, and reduce dose of clobazam if toxicity occurs. With phenytoin, we reduce the dose of phenytoin if you've got levels, if you've got high levels or toxicity. I think I'll end with that, with cenobamate. I'll touch on one other medication that I think is going to make a dramatic difference for a small patient population, namely patients with Dravet syndrome. And that's fenfluramine. Fenfluramine has not been approved. It's under FDA evaluation. Fenfluramine is an old medication. It was started being used in 1970 for weight loss. It's an appetite suppressor. It is a 5-HT releaser and has agonist activity at several 5-HT2 receptors, 2A, 2B, 2C. And in 1980s and 90s is combined with phentermine to provide what was called fen-phen combination that was a very popular treatment for obesity, but led to discovery of pulmonary hypertension and thickening of mitral and aortic valves with cardiac disease and fatalities from both pulmonary hypertension and cardiac death. And was withdrawn from the market. Before it's withdrawn, there's a Belgian group that used it in a group of patients with Dravet syndrome in an open label study of a small number of patients, 8 or 10 patients, and had a dramatic seizure freedom rate. About 7 out of those patients had seizure freedom. And then the same group was given dispensation to do a second open label study, which they did with similar results. And then the medication was evaluated in several controlled studies of Dravet syndrome. 2 of them used doses of 0.2 milligrams per kilo and 0.8 milligrams per kilo. And those doses are significantly lower than the doses that used to be used for weight loss. Much lower doses. And in these studies, the treatment with the higher and lower dose were compared with placebo. The study followed the same design as most controlled studies. The primary outcome measure was reduction of convulsive seizures in patients with Dravet syndrome, and the maintenance treatment period was 12 weeks, titration 2 weeks for a total treatment period of 14 weeks. Well, the results of these studies is also remarkable, and it's shown here. So with the percentage seizure frequency reduction for the 0.2 milligrams per kilo per day is there was 34% seizure frequency reduction over placebo now. And for the 0.8 milligrams per day is 64% seizure frequency reduction, again, over placebo. When you look at the 75% responder rate, the placebo is 2.5%, the 0.2 milligrams per kilo is 20%, and the 0.8 milligrams per kilo is 45%. And strikingly, when you look at seizure freedom, it's about 18% overall. If you add seizures that occurred during the titration period, it's about 25% for the 0.8 milligrams per kilo per day. This is quite remarkable. It's about 13% for the 0.2 milligrams per kilo per day. So you've got a dramatic response for a horrible condition that too may end up changing the treatment landscape. The side effect profile is relatively benign. It includes somnolence, diarrhea, appetite suppression, and weight loss. Those are the main side effects. And the effects were sustained in an open label extension study. So with that, I will end. I think I've gone longer than planned. So I apologize for that. I'd be happy to take questions and then maybe get into the patient-specific utilization of some of these medications that Professor Yarde mentioned early on in the session.
Thank you very much, Professor Klein, for a wonderful presentation of the newer molecules and where they are positioned, what are the advantages and disadvantages. And it's nice coming from you. Many of the studies you have been, taking part, and you have published a lot of this literature with several others who worked with you. We have with us Dr. Sita Jayalakshmi today as co-host, and everybody knows her. She's a senior epileptologist from Hyderabad. And Dr. Sita, please take some questions. Before we go on to that, I would like to ask Professor Klein one question. There have been studies on Perampanel on primary generalized seizures, primary generalized tonic-clonic seizures. And in that study, which I think came from French and Krauss, did they have patients who had myoclonic epilepsy? I think what I remember is there was a subset of atonic seizures, myoclonic seizures, generalized tonic-clonic seizures, and so on. So what do you think is the response? Do we have any data on use of Perampanel in patients of myoclonic epilepsy? Because we have a lot of patients with myoclonic, we don't know really what to do. I'm sure there is not much data on females with JME in terms of teratogenicity, but in general, could this be used?
So that's a very good question. In that study, the outcome was generalized tonic-clonic seizures, and both absence and myoclonic seizures were not quantified. So we do not have data. There was an overall impression that the seizures were improved, but because the seizures were not counted, we don't have quantified data. You're absolutely right about the teratogenicity potential. There is little data at present on Perampanel and pregnancy. So the general counsel is that that we use for all women with epilepsy. If you need Perampanel to control seizures, then you should continue with it during pregnancy because control of seizures is of paramount importance. And if you can, then try to report the patient to one of the pregnancy registries, the EURAP or the North American Pregnancy Registry. But we don't have data on Perampanel and pregnancy and teratogenicity at the moment.
Thank you. Dr. Sita?
Yeah. Good evening, Dr. Pavel. Thank you for the great lecture. We have many questions. I'll try to summarize. First question is, if we use Perampanel with carbamazepine, do we have to reduce the dose of carbamazepine?
I think the answer to that is yes. And I think generally speaking, but I don't use the two together anymore. Carbamazepine will reduce the level of Perampanel by about 50%, and it will reduce the efficacy. So what I usually do is I will down titrate carbamazepine even as I start Perampanel. But you can do it in one of two ways. You can either do it in the proportionate way, so reducing carbamazepine by 25% per week, if you like, or Sometimes people do it instantaneously. I don't like doing that because perampanel does take a long time to reach steady state. 2 weeks. You start with a 2 milligram dose, which is not a therapeutic dose. So you take at least 4 weeks before you reach the therapeutic dose. So I would sort of do it gradually.
Okay, so continuing the same, if you want to add perampanel as the add-on drug, what are the best primary drugs to which perampanel can be added to have the best efficacy in refractory epilepsies?
That's $1 million question, and nobody knows. So we get into the realm of, quote, rational polypharmacy. You'd think that having a anti-glutamatergic, anti-AMPA mechanism would be a significant contribution. There isn't data to say that combination of perampanel with one medication or another is better. Clearly, what we just discussed, combination with hepatic enzyme inducers is not a good idea. But we don't know whether you have better efficacy with between perampanel and, let's say, lacosamide, perampanel and levetiracetam, or perampanel and lacosamide and levetiracetam. We actually tried to do that study, and it's very, very tough to do. And we failed. And one of the reasons why was because the titration of perampanel is so slow. So it takes a long, long time to get to the higher doses of perampanel. So it's a long-winded way of saying that there isn't any data to suggest that. If what I sort of like to do on basis of no evidence at all is use perampanel in combination with a sodium channel blocker. For instance, lacosamide, SV2A modulator, Brivaracetam-Lev Differences, and a benzodiazepine, such as clobazam. Okay. But I don't have any data to say that it does anything.
Yeah, but we are always concerned combining levetiracetam with perampanel because of the significant behavioral issues which occur with both the drugs.
That is correct. And so again, there isn't really any data. There's some negative data to suggest that you don't really have much of a risk of psychiatric side effects going from one to the other. But I would, for that reason, use it with brivaracetam.
Okay, brivaracetam with perampanel.
What about valproate? I mean, brivaracetam, valproate, or brivaracetam, perampanel, valproate, perampanel. How do you think are there any studies? I think Professor Brody mentioned sometimes these combinations in his patients.
So the only quote rational polypharmacy unquote that does have any data to it is the study that you mentioned, which is a study by Martin Brody published in 1999, looking at combination of valproate and lamotrigine, and found that combination to be beneficial. And of course, there's pharmacokinetic interaction because valproate inhibits metabolism of lamotrigine and increases lamotrigine levels. But there aren't similar studies looking at valproate with brivaracetam or perampanel. And it is a great thought because valproate is a very useful medication. It's got multiple mechanisms of action. So that would be another medication to add to the mix in addition to the ones that I mentioned, but no data.
Okay. Actually, there is one unrelated question. Any caution for use of intravenous lacosamide in elderly regarding any cardiac conduction defects?
That's a great question. So lacosamide has the potential for inducing bradycardia. Generally speaking, it's not an issue. It also has potential, but much smaller, of inducing atrial fibrillation and sometimes other cardiac conduction problems. Generally speaking, it's not an issue. With the elderly, I think the question is really a good question. It could be an issue. And I think what I do with lacosamide in the elderly, I do use it, but I do have baseline EKG. And I do a slower infusion over 30 minutes. So you can infuse lacosamide over 15 minutes, you can infuse it over 30 minutes. With the elderly, I'll do it over 30 minutes.
Okay. The other question is, what is the dose of perampanel in status epilepticus?
The answer is none. Perampanel has not really been evaluated in status epilepticus. That said, there have been a few anecdotal reports, including from Duke University, and the doses that have been looked at have been higher than the doses that are used in focal refractory epilepsy. So the highest indicated dose in non-hepatic enzyme-inducing concomitant medications for perampanel is 12 milligrams. For the status studies, the doses have been used of 24 milligrams and a few cases of higher 36 milligrams.
Okay.
But these are anecdotes.
Very high, okay. Yeah, there are many questions about levetiracetam and brivaracetam. What is the guideline from switching from levetiracetam to brivaracetam? What are the corresponding doses? How would you switch a patient who is on levetiracetam to brivaracetam about the doses?
So there are no formal guidelines, but what most people do, and I hinted at it during that study where there was a evaluation of brivaracetam in patients who'd been on levetiracetam and had behavioral side effects. That switch was overnight. And patients there were on 3 grams of levetiracetam, 1500 milligrams BID. They stopped levetiracetam in the morning, or rather they had the last dose in the morning, first dose of brivaracetam at target dose 200 milligrams per day in the evening, and no more levetiracetam. And that's how most people do the switch. In a small proportion of patients, you may have worsening of seizures when you do the switch. And how small is the proportion? In various post-approval studies, it's sort of ranged from maybe 10, 15% of patients. I have had 1 or 2 patients with whom that has happened. And so I now, by and large, do that overnight switch. But when I'm really worried, then I sort of do a concomitant 3-day overlap. And it's purely personal. They have no reason why I should be doing it. It's just fear. I sort of, in those patients, I will keep them on Keppra for 3 days, warn them about the potential for increased side effects, and then stop it, but then stop it suddenly also. In terms of the dose relation, so the switch is usually give or take 10-1. So if you've got somebody with 3 grams of Keppra, you go to 200 milligrams per day of brivaracetam. If you've got somebody with 1 gram of Keppra, go to 50 milligrams BID. There is a dose response between the 50 and 100 milligrams per day. And so I sort of prefer not to go to the 50 milligrams per day. Usually 100 to 200 milligrams. Generally speaking, with a higher dose of Keppra, go to 200 milligrams of brivaracetam. Lower dose of Keppra, go to 100 milligrams. Now, if you got somebody, let's say, brivaracetam is not indicated for primary generalized epilepsy, but there have been reports of its use post-approval, and there's animal data that suggests that it may be effective. So if you've got somebody that has got JME and they're on levetiracetam and they've developed depression and they're on 500 milligrams, then I would go to maybe 25 milligrams of brivaracetam twice a day. But that's not an indicated use.
So if somebody got DRESS, is there a cross-reactivity of DRESS with the other anti-epileptic drugs, and what would you then choose? What's the best drug if somebody got a DRESS?
That's a very good question. Is there a cross-reactivity between DRESS? So in general, there is cross-reactivity between severe cutaneous allergic reaction. So if you've had one reaction, let's say with carbamazepine, your risk of it happening with another medication that is prone to it, like lamotrigine, goes higher. If you had it with 2, the risk goes quite high with a 3rd, let's say, of carbamazepine. So with carbamazepine, there isn't that experience. We don't know, but it would be prudent to assume a similar thing. So if you've in the phase 3 open label study, severe cutaneous reactions were contraindications. So there were no patients with previous severe cutaneous reaction. And you couldn't have had a cutaneous reaction to more than 1 medication. So again, there were no patients with more than 1 cutaneous reaction, allergic reaction. So we don't...
real life situation, what do you do? Suppose somebody, you start him on an anti-epileptic drug and he gets a DRESS. And what is the best drug you can choose? Do you go to benzodiazepine?
So I think benzodiazepine there's plenty of other medications that don't have potential for cutaneous allergic reaction or DRESS. Benzodiazepine, yes, clobazam actually does have that potential. So clobazam is a very useful medication, but in that setting, I probably wouldn't use it. You could use lacosamide, you could use gabapentin pregabalin, you could use SV2A modulator. So you could use other medications. By and large, the worst offenders for DRESS are the sodium channel blockers.
Okay. So if a patient does not respond to levetiracetam, will you still try brivaracetam in that patient?
The answer is yes, because in a proportion of patients, you may still have response to brivaracetam where you don't with levetiracetam. And that goes both for failure of response because of lack of efficacy, as well as abandoning levetiracetam because of side effects.
Okay, the next question is, any role for pyridoxine to reduce the neurobehavioral side effects of levetiracetam or brivaracetam?
So with levetiracetam, it's a sort of, by now, I think, a reasonably standard procedure. You use 50 milligrams of 100 milligrams of B6, and there isn't really good data to suggest whether or not it works, but anecdotally, it appears to be effective in some patients, so it's worth trying. With brivaracetam, there is much less experience. And there is sort of less proclivity for the psychiatric side effects. So it can happen with brivaracetam, but appears to happen significantly less frequently with post-approval studies than with levetiracetam. And the main one is irritability. Depression is sort of significantly less common. But there really isn't the experience to suggest whether or not B6 is effective in that setting. The common sense would suggest that it'd be worth using.
Okay. What is the evidence till now about brivaracetam in pregnancy? Any data we have?
So the answer to that is we don't. It's very similar to Perampanel. In the open label extension study, there were about 40 women with who did become pregnant. Some of them elected to have abortions. There were no adverse outcomes, but there really isn't data at the moment.
Okay. Can we use brivaracetam in children, young children below 4 years of age?
So in the US, you can. I think when I was last time in India a year ago, it wasn't approved for pediatric use, but that may have changed. So yes, you can in general.
Okay. So do you think brivaracetam is one of the best newer drugs for a myoclonic epilepsy also?
So that's a great question. And the answer, of course, is unknown because there's no data. Anecdotally, it does appear to be a good medication. I personally do use it and have had anecdotes, of patients both becoming free of myoclonic epilepsy where they had not been before, and with a handful of patients seeing a fairly notable effect on the EEG. And there was one study that actually looked at that, that looked at roughly 70 patients with primary generalized epilepsy, and roughly a third of them, so 2/3 of those were patients with myoclonic epilepsy, and about 2/3 of them became seizure-free, and about a third of them had significant EEG improvement. But this is sort of post-approval uncontrolled study.
Okay. There is an interesting question about what is the ideal trial design for efficacy of testing a newer anti-epileptic drug?
That's a great question. So we've had tons and tons of medications, tons and tons of studies, by and large, showing very similar results, right? So it makes you wonder, do you want to do the same thing again and again? But the answer is that by luck, it has paid off with Cenobamate. So Cenobamate's trial design was not different. The medication is different. So you've got two issues here. You've got the issue of the medication, and you've got the issue of the design. And by and large, if you've got a great medication, it doesn't matter what trial design you have, because the medication is going to show itself. You know, the trial design of penicillin was N of 1 open label, and it clearly was a cure. So if you've got a medication that's highly effective, the design becomes of lesser importance. That said, it is important, obviously. And we have been looking at the factors that went into the brivaracetam response in the brivaracetam studies, and have shown several things. One of them is that the response of placebo really declines once you get past the 4th or 5th failed lifetime medication. Similarly, the 75% responder rate is a much more important criterion than the 50% responder rate in terms of distinguishing between genuine response and placebo. So those would be two things that going forward that I would consider in changing in the trial design. I don't think we're going to see a change in trial design anytime soon. But if I were to change the trial design, I would do it in the following way. I would have, for the refractory epilepsy patients, a higher number of failed drugs, and indeed Patsevanil, which is the most recently developed medication by UCB. That's a molecule that combines SV2A modulation as well as SV2C and SV2B modulation with GABA-A modulation. That study is designed, or the phase 2B study was designed, and the phase 3 study is designed that way, so that patients are only being recruited who have failed 4 or more anti-seizure medications before. So I would use that as one criterion. And the other criterion that I would wonder about, which has not been universally adopted, would be to set the primary outcome from 50% responder rate to 75% responder rate. Because that really sort of distinguishes between the chaff and the wheat. And it's a curious thing that you've got refractory patients, 30% of whom have 50% responder rate when treated with placebo. So, you know, what makes the placebo response? There's some of it, but the placebo response really declines with the more refractory patients.
So we've had a fantastic time with Dr. Pavel Klein. He's given us a very good idea about the new drugs and where we stand in respect to those drugs. And he's been kind enough to answer a lot of questions that came up. And we've well gone over an hour. So I think we might just thank him and for his time and his knowledge and fantastic talk that he gave to us. Thank you, Dr. Sita, for co-hosting. Thank you, Dr. Sudhir, and all the people who have been sort of backing this up to give us this lovely fine night webinar.
Thank you, Yadi, and thank you, Pavel.
Thank you, Sita. Thank you, Yadi. Take care.
Yeah. Thank you very much. Take care and be safe.
Lockdown.
Yeah. Thank you.